by Dr. Mihir Kothari, sir. It is on accommodation scale, a ruler gauge for objective assessment of magnitude of accommodation in kids.
The first one, first folder. Hi, you can do that. So good morning, my colleagues. Here I am quite excited to present a new scale which you will be able to use for objective assessment of accommodation in your pediatric patients. I have no financial disclosures to be made. Accommodation abnormalities, many of you are aware, is not uncommon in children. As many as 80% children with Down syndrome, 50% children with cerebral visual impairment, and a significant number of children with foveal hypoplasia, ectopia lentis, suffer from accommodative abnormalities. Accommodative abnormalities are also seen in patients who have unilateral or bilateral amblyopia, various strabismic disorders, patients complaining of sthenopia, and patients started on various concentrations of low-dose atropine. Current clinical methods like dynamic aberrometry and open field autorefractometry are less accessible, quite expensive, and marred with underestimation of accommodation, and hence most of us, the clinical pediatric ophthalmologists, would like to rely on dynamic retinoscopy. In our 2019 survey of the group of pediatric eye surgeons of Mumbai, less than 5% pediatric eye surgeons were confident enough to be able to use dynamic retinoscopy when it was required. We described this technique in which photorefraction was used when the child was looking at a longer distance, and then the distance was reduced, and the accommodative reflex in the transpupillary area changed from superior crescent to an increasing inferior crescent as the distance was reduced. As visible in this particular video, when the child is looking at distance, the crescent is up, and as the child starts looking at near, there is a prompt reversal of the crescent inferiorly, which keeps increasing as the distance keeps decreasing and the accommodation keeps increasing. These were validated in two studies, 2012 and 2019, in which we found the technique of dynamic distance direct ophthalmoscopy as well as estimation dynamic distance direct ophthalmoscopy was having near 100% correlation with current gold standard of dynamic retinoscopy, albeit it had better sensitivity. When combined with a neutralization technique like what we do for minimum estimation method of dynamic retinoscopy, you can neutralize this inferior crescent and find out the exact amount or the magnitude of accommodation that the child is exerting when looking at a fixed near distance. However, this technique was also not picked up by our colleagues in Mumbai, and hence we decided that let's get away completely with the neutralization insertion or interjection of the lens and create an accommodation scale which can be used and compared it with the dynamic retinoscopy and validated again on the same group of pediatric eye surgeons. The way the scale was derived was we asked the child to look at a distance. This child was emmetropic, and while looking at a distance, we introduced or interjected the positive lens in the step of 0.5 diopter from 0 to 5 and derived this kind of a scale where there are 11 serial photographs showing an increasing amount of crescent. This scale was quite similar to the previously used scale in ophthalmology, like the Kestenbaum scale for pupillometry or the ulcer scale or the JLC grading card used for cup disc ratio, AV ratio, etc. We compared this scale in normal subjects with dynamic retinoscopy, and we needed 15 eyes for 90% power of the study at 5% significance level. A pediatric oriented optometrist doing her M-Optom included 5 to 16 years age children with normal systemic health visiting a pediatric eye clinic for routine refractive checkup and were cooperative for both the tests. We had 17 children, of which 10 were males, and we performed these tests at 100, 50, 33 and 25 centimeter. As you see over here, there was a very good correlation between the two techniques. However, accommodation scale had less intra-test variability, while dynamic retinoscopy had a higher standard deviation and picked up lead of accommodation, which is quite common with interjection techniques. Then we validated the same scale among our pediatric eye surgeon colleagues on 10 different slides, as you see over here. With a 5.8 years experience, we found they were able to assess the magnitude within 0.25 diopter, and 95% were confident of using it. The only problem or the limitation is it is still an interjection technique. It is best to use an Android or iOS app which can take the photograph and automatically tell us about what is the actual accommodation. So it is quite easy and useful tool for assessment of accommodation in regular clinic. You may use an accommodation scale. Download it from drmirkothari.com. Thank you very much.
Thank you, sir. Thank you for a very novel approach for dynamic retinoscopy. Just out of curiosity, I would like to know, how did you video record the reflex when you actually showed it?
Just like you put your eye behind the ophthalmoscope, you put your iPhone or an Android phone behind the ophthalmoscope.
Okay.
You can use an app also. It is called DM Eye Care app, which was invented in US, basically to pick up the retinoblastoma using the transpupillary reflex. If you take this MD Eye Care app, you can also derive these photographs. It requires darkness and calibration in the dark room. Focus when the light is on, then switch off the light, then take the photograph, then you can pick it up. MD Eye Care is the app.